Conference for clinical officers and physician associates. I bring greetings from India, a land of extraordinary diversity in its culture and people. As Sir said, I'm a cardiothoracic surgical associate with experience of more than 14 years. And I'm a proctor for endovascular vessel harvesting, and I trained PA and doctors globally across. And I'm a vice president and academic lead IAPA. I've been involved with IAPA and its functions since 2012, quite a long time. And I'm proud to say that I'm also involved in the national standardization of curriculum for PA education in India 2025. That draft curriculum has been submitted to the National Commission of Allied Health Science in the beginning of this year, and it has been recognized and accredited in the month of April 2025, and it is going to be established and followed in the next academic year 2026. I speak today as a strong advocate for a global vision that unites all of us under one purpose: to strengthen and standardize our cadre to serve the goal of universal health coverage. I have been asked to focus on Asia, the world's most largest and populous continent, covering a vast and vibrant range of culture, language, faith, climate, economy, and a health system. I give an overview on initiation of this PA program in the Asian countries, and particularly focus on India universal health coverage and PA role into it. One vision, one cadre is a call to align its title, training standards, scope of practice, and regulatory recognition for clinical officers or physician associates and their comparable into a single integrated global cadre. The aim is not to erase the national identity. The aim is to establish a common baseline, comparable competencies, transferable credentials, and clear role descriptions that patients and the health system can rely on internationally. We are at the moment where the world urgently needs more adaptable and skilled health workers. Clinical officers and physician associates are the proven solution for it. But the progress has been slowed down because, as we all been discussing for the past 2 days, because of this shattering titles across the globe. We see different titles, inconsistent curricula, and variable scope of practice. Asia is home to over 4.7 billion people, nearly 60% of the world's population. With extreme diversity in economy, health system, and workforce capacity, some countries offer near UHC, while others rely on private spending. Disease burdens are also shifting from infectious disease to non-communicable diseases in South and Southeast Asia, and aging population in East Asia. Asia faces workforce shortages, especially in rural areas, which remains a major challenge. As Scott said, Asia is one of the first regions to educate and train an alternate clinical practitioner and share the medical responsibility with the clinical practitioners, such as Felshers, which has been established in the 17th century in Russia. Next, the Malaysia developed their own auxiliary medical person with a title called apothecaries in 1786. Now they are titled as assistant medical officers. Today there are more than 17 different PA and PA analog education qualification in 17 different countries in Asia. Bangladesh, the equivalent of a physician assistant, is called a sub-assistant community medical officer. The state medical faculty in Bangladesh conducts this program, and it is licensed by Bangladesh Medical Council. Bangladesh PAs are licensed to prescribe a list of 73 basic medicines. They conduct a 4.5-year program with 4-year academic training and with a 6-month internship. The equivalent of a physician assistant in Nepal is called health assistant. The HA program in Nepal is a 3-year training program focused on preparing the individuals to provide basic healthcare services, especially in rural settings. There is ongoing discussion and interest in developing formal physician assistant program in Nepal, potentially drawing out from this existing HA training and adopting the best practices from other countries according to some healthcare and education publications. Russia, the feldsher, it's a physician assistant prototype developed in 17th century. During wartime, many served in the military as medics. During the late 20th century, feldsher's number waned compared with the physicians and nurses. In the 21st century, they remained in the presence of Russian medical system, but their future were in transition as their number declined. However, this year, Russian President Mr. Putin urged the Russian state government to create more feldsher in rural areas. This indicates the Russian government at highest level see the need for more felshers to serve essentially as PAs in remote areas. Australia initiated a PA program in 2010. Currently, at James Cook University offer a PA-focused degree called Bachelor of Health Science PA, though its current status and availability are limited. Earlier, the University of Queensland had such a program, PA program, but no longer operates. As mentioned earlier, Australia has no formal national registration or regulation. Saudi Arabia initiated a PA program by a Saudi Ministry of Defense in collaboration with George Washington University, and they are designated as assistance physicians. Despite the training, the assistance physicians are not formally recognized. Afghanistan initiated in 2010 and developed by a NATO training mission as a part of an effort to bolster the health workforce, especially among the military personnel. It's a one-year academic training program with 16 weeks of clinical rotation in emergency and trauma care. There is no established civilian PA program yet. India. India started a PA program in tertiary care. A doctor called Dr. K.M. Cherian, he did a fellowship in United States of America, Alabama, where he came across with the PA first. So then he came back to India and started his own career in cardiac care in a hospital, Madras Medical Mission. He found there is a significant lack of mid-level health service. So he thought of starting a physician assistant program in India for his own hospital. So the initial curriculum for PA program was completely designed for cardiology and cardiac surgery, and the initial set of PAs who came out in first decade were into only cardiac specialty. So the program started as a PG diploma program in the year 1992, and the first batch of PA graduated in 1994. The Indian Association of Physician Assistants was founded in 1998. 3 decades of Indian PA profession, as I mentioned earlier. The first set of PAs entered into the cardiac care, and slowly they migrated to the other specialty, and now Indian PAs are almost into all the specialties. Evolution of Indian PA education has started as a PG diploma course, and then to masters, and then to undergraduate program, and now it is like undergraduate, postgraduate and PhD most accepted pattern. Initial challenges faced by Indian PAs was an identity crisis, neither doctor nor nurse. Slowly, PAs proved by themselves and became a vital force in the private healthcare system. A lot hard work and effort of Indian Association of Physician Assistants had led to a national accreditation to this profession, and I am proud to announce that Mrs. Gomati, our president, IFPA, had been elected as a National Council member under the National Commission of Allied Health Profession. These are the milestones for Indian PA profession. This is the picture, so shows the drafted curriculum which has been accredited in the month of April. A role of PA is going to be an impact in universal health coverage. A population density analysis of these data shows that Africa and Southeast Asia, which are the poorest region and which also have the greatest burden of preventable disease, have the lowest density of health workers. UHC deadlines are near. countries committed to UHC by 2030. The world is facing projected 18 million health worker shortfall by 2030. Shortage hitting primary care and rural services hardest. Solution for this is standardization, standard competency framework, consistent assessment, and relicensure requirements limits the variability and reduce the malpractice risk across the globe. India's universal health coverage effort is primarily driven by Ayushman Bharat, which has been launched in 2018, aimed to provide health assurance to vulnerable population, to reduce out-of-pocket expenses, and to improve the access to secondary and tertiary care. While India has made a significant stride, achieving true UHC faces challenges like improving the public health infrastructure, increasing the number of skilled health workers, and bridging the significant regional disparities in service quality and access. This is where a well-trained PA or a clinical officers can make a difference. Expand the health system reach efficiently, contributing to broad healthcare service delivery and support the UHC goals. If we align one vision, one cadre, we can unlock the full potential of this workforce, scaling up faster, saving where needs are greatest, and contributing meaningfully to the UHC. PAs are going to be a game changers. We have added decades of evidence showing clinical officers and PAs improve access, quality, and cost effectiveness, especially in primary care and underserved areas. So by integrating PAs into the national UHC strategy with clear scope and standardized competency, countries can bridge critical workforce gap and move closer to equitable quality care for all. I conclude with a recommendation: advocate for an international collaboration to establish a standardized curriculum worldwide, support the adoption of unified accreditation and certification process to ensure the competency and quality, encourage the stakeholders to develop global platforms for sharing best practices, and continuous professional development for educators and students. I sincerely thank Professor Filberg and Mr. Haston for giving me this wonderful opportunity, and I deeply thank my president, Mrs. Gomati Sundar, for having a huge trust and giving me this opportunity to attend this event. Thank you.